And we know, for example, that one of the factors that determine extra factors that are accounting for the addiction risk is the stage in neurodevelopment at which you get exposed to drugs. Such that if you are a teenager and you get exposed to drugs, you're at higher risk of developing addiction, considering equal weight of genetics vulnerabilities that if you take drugs later in life. But I want to emphasize, though, on the right side of what the factors are there as identified as environmental. Because environmental factors are crucial in determining the risk of someone to become addicted, regardless of what their genetic risks may be. And environmental factors, of course, are going to be determining playing a very important role in exposure to drugs during adolescence. But also environmental factors are going to be determining resilience to the transition into escalated drug use and addiction. And through science and technologies, we now can start to address in a better way that we've known just from epidemiological studies that adverse environments, particularly during childhood and adolescence, are factors that significantly increase their risk for addiction. We've known it all along. What we do not know is why, nor do we know why is it that genes increase the risk of addiction. And it is very likely that genes increase the risk of addiction to a certain extent by the way that they modulate our responses to the environment. And with tools now, we can start to integrate that interaction between how genes influence our reaction to the environment and how genes influence the brain in ways that then drives our reaction to the environment, and how that then leads us to an understanding about what are factors that will result in someone becoming addicted. So this is an old study now. It was published in 2014, but it's a very elegant and simple that illustrates how malleable, how different the brain is from early infancy, there are years 5, 8, 11, 14, and 17. And what you're seeing are the changes in brain volumes of the brain of individuals of different ages, from 5 to 17. And in the lower panel, you can differentiate, the researchers have differentiated between the influence of genetic versus environment. And the way that these studies do it is by comparing the similarities between twins in terms of the brain structures who are identical, which share exactly the same genes and basically the same environment, versus those of discordant twins that basically share the same environment overall, but do not share the same genes. And this is a strategy that has been used successfully for a wide variety of medical conditions. Using this strategy, for example, the investigators show a very interesting finding, and that is the significant the significant importance that environment has, particularly during childhood. And so this is the influence, the greater the color here, the greater the influence of the environment, the greater the color here, for this row here, the greater the influence of genetics. And what jumps immediately is how crucial and sensitive the development of the child's brain to the environmental exposures. And this is most notable at age 5, 8, and 11. It continues to a certain extent, but much, much lower later on. And the message that we get from this is that interventions that are actually for prevention are likely to have the greatest impact when initiated early in childhood. And you can also interpret this to say that children living in very adverse conditions, particularly during their early childhood, are much more likely to be negatively affected than if they were exposed to those environments later on. On the other hand, we see that genetics has an influence that persists for a longer period of time vis-a-vis the changes in brain morphology, brain volume. And this study also shows us something that's interesting, because you are seeing some regions of the brain that are more affected than others. And either on the environment, for example, it's notable that the superior frontal cortex and these superior temporal cortices are more sensitive to the effects of the environment in terms of the changes in brain volume. And these structures happen to be of great relevance in general for mental disorders, including substance use disorders themselves. Now, this brings us to something that has been very, very widely discussed and that is creating a lot of interest in the United States, and I think perhaps brought by, sensitized by COVID, because we've realized that the mortality and the burden of COVID has been much greater among individuals that come from underrepresented groups in the United States that are also the ones that are more socioeconomically deprived. And this goes into our understanding now for years. It's not that it's new, that the social determinants of health are crucial in the well-being and in the outcomes of individuals and their life expectancies. We've known that, as I say, this is not new. And we know that it is childhood experiences crucial, family income, education, and access to health services. All of these are crucial in determining what's going to happen to your health. As it relates to adverse childhood experiences, and I highlighted them because it has been shown that they play an extremely large role in determining the risk for a substance use disorder. And it's a cumulative role. So if you are a child and you have one adverse childhood life experience, which could be any of the ones portrayed here, you have higher risks. But if you have 4 or 5 or more adverse childhood life experiences, your risk of developing a substance use disorder is increased tenfold. So there's almost like with cancer, a cumulative effect in terms of the more you get exposed to these adverse childhood environmental exposures, the worse the risk that you have as it relates to substance use disorder. Now the question is, of course, why? Now we know, for example, already from studies that have been going on brain imaging, that, for example, and this is the data shown in here, that children that have been brought up in an orphanage, when the researchers measured the strength of the connectivity of the white matter tracts using diffusion tensor imaging, they've shown that those children that live in orphanages have significantly weaker connections in, for example, the using a fasciculus connections, which are very important in linking actually the ventral parts of your prefrontal cortex with the limbic parts, the amygdala, crucial structures for actually mental health and substance use disorder. And they've also shown that the longer you've been in an orphanage, the greater the deprivation, the worse the outcomes in terms of this measure of structural connectivity, of the architecture of the brain. These studies actually overall have been small in samples, and so what we initiated last year in September of 2021 was a very large longitudinal study that aims to follow 7,500 infants with at least 15% of them recruited with mothers who were exposed to opioids during pregnancy, many of them on very adverse socioeconomical environments, to try to understand in a prospective way how that influences the brain in the context of genetics. This study was very much actually inspired by a study that we launched in 2015 by the name of Adolescent Brain Cognitive Development, or ABCD study, that has followed since then almost close to 12,000 children at the time, 9 to 10, as they progress into young adulthood, in principle for 10 years. These participants are imaged every 2 years, and they are evaluated on a yearly basis for cognitive performance, for behaviors, for social interactions. And the data is deposited on an annual basis in an open access so that researchers from all over the world can take advantage of it and analyze and explore scientific questions. And as a result of that, and because the ABCD study did an in-depth characterization of the social environments of these children, we have gained an enormous amount of knowledge about how these social determinants of health, when they are in the childhood life, how they are influencing the brain development. So let me give you an example. This is a study that I was involved with in terms of the analysis to try to understand ultimately Why is it that in the United States, for example, children that come from underrepresented groups tend to perform worse at school or in cognitive tasks? And why, if you just look at these parameters in general, you also start to see differences in brain morphology. And what this study showed unequivocally was that the factor that's driving the differences is the family income that the children live on. And that is what accounts for the differences between the groups, such that this illustrates it in terms both of cognitive performance as well as the measures of brain morphology, cognitive performance for crystallized intelligence, which basically reflects mostly to language, versus fluid intelligence, in green. And you can see that those children that come from high family incomes have the highest scores, cognitive scores. And in parallel, these are the children that have largest brain volumes. And these are the areas with the relative influence of the income on the development of the brain that are most sensitive. And this indicates that, and again, is what is interesting to me, is that it is an actionable item. Income is something that you can actually try to target. If we educate these children with high quality education, then they will be able to grow up in a way that you can actually counteract many of these negative outcomes. And it's interesting, too, I found it very intriguing, that one of the areas that's most sensitive to the low income being brought up in a low income is the superior frontal cortex, as well as the anterior cingulate cortex, which is a key region for self-regulation and control. And you will see it consistently being reported as one of the areas that predicts a greater vulnerability or resilience against substance use disorders. So we had known, and I bring up the data from, for example, with the ABCD study showing how being brought up in a low-income family can put you at greater risk of cognition, and you ask, well, why? Well, if you think about it, low-income families, both parents have to be working. Many times, the parents have to work more than one shift, so they are not there to stimulate their children to do their homework. They are not there, for example, to ensure that they go to bed at the time they are supposed to do that. They don't provide them for the stimulation because they don't have the resources. And they live in neighborhoods where the quality of education is much lower. And that can be tested, it's a testable hypothesis. But we already know for prevention studies, and there's a lot of prevention research that has been going on, that the prevention interventions work. And they are based on two precepts. One of them is decrease the risk factors that, as I said, have been identified by epidemiological studies, and enhance the protection factors. And take advantage of, depending on what is going to be your prevention intervention, to do interventions that may be targeted to the individual. For example, if you have early aggressive behavior or poor social skills of basically impulsivity, those are interventions that you can target at the individual level. But we know that the family plays a key role. And we know that families where there's a lot of social disruption, where the parents are taking drugs, where there's not emotional support or attention, are associated with much higher risk. So for example, interventions that target the parents to improve how to parent their children have also been shown to lead to much better outcomes. And so for all of the other indicators, individual, family, peers, school, community, prevention interventions need not be limited to one, but actually tailored to the particular group or population or individual that you're going for, and they work. And there's a significant amount of work that actually independently have shown that they actually have significant effects in decreasing the risk for drug taking, in decreasing early pregnancies, in improving mental health, in improving education, in improving, reducing the risk of obesity, for example. So they have not just positive effect overall in drug taking, but positive effects in medical health and well-being. And so what is it that's mediating? That's part of the scientific question to me that is very interesting. And it's very interesting because if we understand that we may have biomarkers by which we can then target an intervention and see, can I improve that biomarker, and then that biomarker can predict that I'm going to be effective in preventing the substance use disorder. And so I'm showing you two studies. One of them is very recent. It was published in PNAS in 2022. And it attracted my attention because it was an action intervention. They took, it was around 400 participants, mother and infant. The mother was pregnant, so the infant had not been born at that point. And they divided the sample into those mothers. All of them were poor mothers. And they gave them approximately what it was equivalent to their 12% of their income, annual income on a monthly basis. And they gave it to them and said, you do with it what you want to do. And in the other one, they gave a nominal quantity. And then they monitored their infants when they were 1 year old with EEG. And they showed what, first of all, the low cash gift group on these the women who were pregnant during with very, very poor incomes, what they were expecting. In general, these studies have shown that they have higher amplitudes in the low frequency way. So this is the EEG, low frequency versus higher frequency. And they see that when they compare the low cash gift, which was basically nominal as a control, versus the 12% cash, which make a difference for them in terms of what they could buy, they see on the one hand what the main effect is a significant increase in the high frequency band, and you can see it here. And this is relevant because increases in high frequency on the EEG of infants at 1 year have been shown to basically predict better cognitive performance. And to me it's interesting because it's an intervention that you are giving cash to a mother during pregnancy, and that significantly improves this biomarker that has been associated with better cognitive outcomes. And the other is an older study, was published 4 years ago, 5 years ago, and it is actually more of a population study that targeted African families that were also very poor, in which what the intervention was, half of the sample was they did an intervention that actually teaches the parents how to parent their children and also intervenes with the teenagers, and then they follow them as they go into young adulthood, at which time they measure brain morphology. And they show that in this case also the intervention significantly prevented the reduction in volumes associated with greater years of poverty. The greater the years in poverty, the smaller the volumes in the amygdala and the hippocampus. Well, this intervention actually prevented this trajectory on these young adults that were benefiting from it, indicating and showing how powerful the environment is to modify the individual trajectories of someone in a way that can actually lead them to give it greater chances for better outcomes or make them more vulnerable, for example, to improper self-regulation and impulsivity. Within this context about how crucial the environment is and how many of the mediators that we see with poverty are associated in, for example, in terms of women, and again, a lot of research has been done on this, that when women are pregnant with high levels of stress, for example, their newborns are actually have significant changes in white matter structure. So the stress itself in the pregnant women negatively influences the infant. But with COVID, everyone has been stressed, pregnant women, infants, adolescents. And so the question that we start to ask ourselves, how is that influencing overall people, and how are we responding to it, and are there some people that are more vulnerable than others? And I started my presentation by saying, it's almost like when we're speaking about social determinants of health and we're speaking about adverse childhood environments, COVID pandemic is an adverse childhood environment for certain children, particularly if they are in households where it has negatively affected them, where they lost a parent, where they become orphaned, where they lost jobs, where they are separated, where they become sick. Whereas it may not be such a negative impact into someone that has the resources. So we supplemented, the moment that COVID came in 2020, we supplemented the researchers from the ABCD study, which is the 12,000 adolescents that we've been following, to actually ensure that we were creating questionnaires to survey the consequences of the COVID pandemic in these teenagers. Now they're starting early stages of teenagers and their families because of COVID. And I'm going to present one of these studies. There have been several already published. And again, all of this data is widely accessible for any one of you to analyze. And what it shows is, in this case, how are these teenagers responding to COVID pandemic in terms of reporting sadness, positive affect, fear, or worries. And what these investigators show is that the responses are very much determined, vary from by different children, and that the number of adverse childhood environments that those children had been exposed before the COVID pandemic predicted how badly they were going to react or not to the COVID pandemic. And for example, it is those children that have the greatest adverse childhood exposures that have the lower positive ratings of positive affect. On the other hand, are the ones that are experiencing greater sadness, fear, and worry. We do not see negative effect on those children that actually had not had adverse childhood experiences. Again, illustrating that we're creating a group of children that are becoming increasingly more vulnerable as they translate, almost like a domino down effect. And so that our prevention interventions need to stop that. Well, that is children. Well, what about adults? And as Dr. Benjamina was saying, I wasn't able to attend the conference because the COVID pandemic has exacerbated horrifically the problem that we had with the opioid overdose crisis, which was already the most severe we had ever had in the addiction history of the United States. So the COVID pandemic made it worse. And in a way, it's not surprising, because we know, just as we speak about teenagers and children, that adverse social environments make you more vulnerable. We'll know that's also the case as it relates to drug taking in adults and as it relates to relapse and escalating drug use, among others. And among those that already have an addictive disorder or a substance use disorder, the situation becomes much more challenging. What happened with the COVID pandemic? All along, we have struggled, and we continue to struggle in the United States and in many countries in the world, of the stigmatization of the people that take drugs and of people that are addicted all along. And as a result of that, that has been one of the most negative consequences, because on the one hand, the healthcare system has actually used this as a way of neglecting the responsibility that they have for the screening and treatment interventions for those suffering from a substance use disorder. But it also has stigmatized the willingness of payers to actually reimburse for the treatment of individuals with substance use disorder. So there's a recent paper that just came in one of the German journals that, for example, was comparing the level of reimbursement that an insurance will pay for someone that is treated for a substance use disorder versus someone that may be treated, for example, for a metabolic disorder. So there is a stigmatization at the level that the healthcare system looks at the value of treating people with a substance use disorder, but also the insurance. And it becomes like a positive feedback loop, because clinicians are not going to want to treat patients if they are not reimbursed properly. And that is something that we're seeing, for example, in the United States. The other issue is that stigmatization has led to a mishandling of individuals with a substance use disorder. For example, in the United States, and this is the case in other countries, there has been an over-criminalization of individuals that possess drugs, that use drugs, and they end up with a higher likelihood of ending up incarcerated. And this issue, in turn, has also been applied to particularly much more severely to certain groups, like Black Americans. And you can see, for example, in this picture that I show of a prison in the United States. I don't know if it's a prison or a jail, but you can see I didn't select it, I just pick up one in the Google, the images, but then you see everyone is Black. And when I visited jails myself, it just jumps at you. Everyone looks to be Black. And I think that is an aspect that has allowed structural racism to persist, that criminalization of drugs enables you to selectively apply it one way to one group and not so stringently into the other. And that has been one of the aspects that has been very, very negative, among many other things about the criminalization of people that take drugs. But when the COVID-19 hit, in a situation of stress, I always think about, and I haven't lived a situation of greater stress than the COVID pandemic, that it exposes the greater vulnerabilities that you have as a society. And these are the things that are being exposed. These structures that we've generated that are making these people much more vulnerable. And guess what happened is people in jails and prison were much more likely to get infected, much more likely to die from COVID. Also, it was people that were taking drugs that then were much more likely to end up homeless, and the homelessness population increased in the United States. And the greatest rates that we saw of deaths from overdoses in the United States are among this homeless population. And this is actually also a picture just before the emergency declaration on a methadone clinic. This is the way it was. So we do not put the resources, we basically force people to go to treatment on conditions that we don't force for any other patient suffering, since I'm discussing it, metabolic diseases. You never have a situation like this for treating someone that has diabetes, but we do that. And we seem to have incorporated it, and we don't question it. And I think that COVID has forced us to question it, because there's no justification for any of these things that we see observed here. So, but this was amplified by the COVID pandemic. People lost their jobs, poverty went up, people became homeless, people lost access to treatment, people lost access to social support systems. So you may imagine, since we've been in a meeting of addiction, that all of these will have negative repercussions, particularly, again, among the most vulnerable. And the answer is, of course, yes. And the COVID pandemic came, as I said, in the worst overdose crisis that the United States has ever had. So how did it affect the overdoses? And the next slide, before I go there, shows how it affected, ultimately, the outcomes for getting COVID among people with substance use disorder. First of all, we observed that the risk of infection were significantly higher, regardless of the type of substance use disorder that you had, than those that did not have it. So if you had a substance use disorder, you were, in average, 8-fold times more likely to get infected. And there are multiple factors that account for that higher risk for infection. But importantly, look at the data in terms of mortality. This was at the beginning of the epidemic, so this was the rate of mortality in the general population. This was for Black Americans, this is for white Americans. And this captured the attention of everybody. More Black Americans were dying, yes. And that also now has brought attention to the health disparities that we have between blacks and whites in the United States. But look at the difference with individuals with substance use disorder. They were basically at more than 50% more likely to die if they got infected, particularly if they were African American. So you saw it also in the white. I mean, there's a significantly higher risk of death among people with substance use disorder. And when we look at that data to try to understand why is it that, well, we can hypothesize why they were greater risk. And the question is, why are they dying much more if they get infected? And so it forces us into looking into the electronic health records to see what the history of these individuals were. And we uncover something that I've been aware of has been very neglected. But I basically, this data highlights why we can no longer neglect it. And I think that in this meeting, some of these issues have come to the fore. Individuals with a substance use disorder, here you have in red versus those that do not have. And these are comparisons on populations where we have matched them for sex, for socioeconomics, for insurance types, for education. We see that the rate of a wide variety of medical conditions are significantly higher. And when I speak significantly higher, it's at least 3-fold higher among individuals with substance use disorder. What are notable, we see on 3 times, at least 3 times, type 2 diabetes. We see almost 3 types cardiovascular disease. We see also more than 3 types hypertension. We see more than 3 types obesity. I mean, obviously we knew about HIV, and obviously we knew about cancer because of smoking. But this is not just observed with people that are smokers. This is observed about individuals with a wide variety of substance use disorders. And what is this basically reflecting is, again, this disregard and in part the discrimination that we have about individuals with substance use disorders. They themselves incorporate that discrimination, and they don't seek out medical care because no one wants to be discriminated or mistreated. And to that extent, what we're observing is individuals with substance use disorder, both because of the negative effects of the drugs themselves, but also because of the lack of attention to their medical conditions, develop them more severe, more chronic, and therefore, if they get infected, when they get infected, have much worse outcomes. But this is the data for, so you saw greater mortality from COVID, greater mortality from overdoses. And what you see here is the mortality per month from January 2019 to March 2020 in the lighter purple, and in the darker purple, the mortality between April 2020 and May 2021. So this is the period of the pandemic, this is the pre-pandemic period. This is overall overdose deaths. And you don't need to do any statistics to see how rapidly they jump. And overall, the first year of the pandemic, we observed a 30% increase in mortality from overdoses overall. And most of those those overdose deaths are driven by opioid involved. And opioid involved can be prescription opioids, which is how the overdose crisis started in the United States, heroin, or synthetic opioids, which is the most powerful driver of the overdose crisis in the current moment. And this shows it here. These are for synthetic opioids, predominantly fentanyl, illicitly manufactured fentanyl, and analogs of fentanyl. But you can clearly see that there are very striking difference before and during the pandemic. We've also seen increases in psychostimulant involved. Don't ask me why, but they like to call methamphetamine psychostimulant involved, distinct from cocaine involved. But you can see also an increase in the number of deaths from methamphetamine and other synthetic drugs. So what happened? What is it? Yes, on the one hand, we have the stressors from the pandemic that are likely to be driving drug taking, but is that everything there is? And I think that if you look at the latest numbers, let me see if I have the latest numbers. Yes, I have the latest numbers from CDC, go up to December 2021. I wish I had the data for May 2022, but that data is not available yet. And in the past year that ended on December 2021, we saw a total of 107,000 people dying in 1 year. So currently in the United States, we are seeing more people dying from overdoses than we are seeing people dying from COVID. And that is the reality. And the other issue that is very, very concerning too is when you look at the mortality of people that are overdosing tends to be much younger than that of people that are dying from COVID. And I bring this up not because I value the life of a younger versus an older person. I mean, that of course is a very subjective statement. But younger people tend to have greater responsibilities as they relate to the well-being of their children. And so what we are observing is that these overdose mortalities are paying a very, very large toll on living children who are orphaned because of the overdose crisis. If you look at the numbers and again, what happens when you become an orphan, that actually is one of the most adverse childhood experiences. So you can start to see the downstream negative effects, not just for the individual itself, but for those that are close to them. When we look at the different drugs, you see that the decrease in mortality from heroin is contribution to mortality has gone down. Prescription opioids, which started the whole opioid crisis, has gone down. And methadone, and I want to comment on methadone, because in the United States, as it was the case of many, many places, with the emergency declaration for the pandemic, there were changes made so that it was much easier to take methadone home, so methadone from the methadone clinic than it was before the COVID pandemic. So it was possible for patients to take 1 month of doses of methadone. And this was criticized by many because they say it's going to result in diversion of methadone. We're going to see an increases in overdose deaths. Well, we have not seen it. Actually, the simplification of the pattern of access to methadone with take-home methadone doses for 4 weeks has not resulted in an increase in overdoses from methadone. But it has resulted in improved outcomes. But look at synthetic opioids in terms of fentanyl increase, cocaine increase, methamphetamine increase. And I do want to note something because it's actually an aspect of what we're seeing more and more is that at least 60% of the mortality of people with methamphetamine also contain fentanyl. And similarly with cocaine, 75% of people that die from cocaine also had fentanyl in their blood. And this reflects the fact that more and more the illicit drugs in the United States are being contaminated with fentanyl. And that drives their lethality. So it's not just people that are seeking out opioids that are now basically vulnerable to overdosing because they may purchase cocaine, they don't know that it has fentanyl, they have no tolerance for opioids, they overdose. And similarly for methamphetamine, and similarly certainly for heroin, and that has been known for a long time. But this is the other aspect that made the situation so much worse during the COVID pandemic. These are drug seizures from 2014 to 2020 in the lower part, where we actually see for cocaine, methamphetamine, heroin, and fentanyl. This is the only year in here where we have pandemia, the 2020, and you can see the steep rise on methamphetamine seizures. And look at the steep rise every single year for fentanyl. And this is what's driving the very precipitous rise in overdose mortality. Throughout the whole 2 years of the pandemic period, we have had almost a 50% increase in rise of mortality. And this is likely fentanyl, the one that's driving that mortality. That's 2020, so I added the data for 2021 to see this is 2020. Okay, you just see already. Look at the steep rises that we're seeing in 2021. So there has been an acceleration of the distribution of fentanyl within the United States in urban areas, in rural areas, in suburban areas. It's everywhere. Demographically, all of the groups are being negatively affected by it. And this is happened very, very rapidly. And I bring it up in the context, of course, on our European Congress, because I do realize that this problem is currently not present in Europe. But if you look at it in terms of, in a period of 4 years, the dramatic rise that we've seen of fentanyl entry into the United States. And my fear is, of course, as the dealers saturate the market in the United States, they will start to look for other countries where they can bring their products. So what do we do? And I've been asked that question. Well, what is the United States doing in terms of addressing the overdose crisis? And we are an agency of research, so we just do research. And one of the things that we have when these are opioid overdoses, whether it's fentanyl or heroin or OxyContin, and you overdose, we have treatments that actually are very effective if you have an opioid use disorder. We have methadone, we have buprenorphine, we will have naltrexone, particularly extended release naltrexone, and all of them are beneficial. And if you overdose and we give you naloxone and we give it to you at the correct dose and rapidly, we can basically recover you. Naloxone is an extraordinarily effective drug in reverting overdoses. And it's effective in reverting the overdoses from fentanyl. It's effective in reverting overdoses. Fentanyl is 50 times more potent than heroin. It's effective in reverting overdoses from carfentanil, which is at least 50 times more potent than fentanyl. The challenge is to administer it rapidly and at the correct dose, and that's not always happening. But the other challenge that we have is, while we have these medications that are very effective, it's probably the most effective intervention that we have for preventing overdoses, and I will show that the latest data I could get my hands on. We have only 18% of people that would benefit from these medications getting access to it in the United States. And so in my view is that we can develop science that is very transformative, that will give us really very powerful tools in 5 to 10 years. But we don't have that luxury right now. We also need to attend about what is it that we can do to specifically improve this. How do we change it? Well, this is the data I promised you. This is data I just published recently. These were women that were pregnant with an opioid use disorder, and showing the percent reduction in risk for a non-fatal overdose. Otherwise they wouldn't have been able to do the study, they had died. And depending on how many weeks the women were on medications for opioid use disorder, 10, 20, 30, or 40. This is the whole pregnancy. And you can see that if the woman is on medications throughout the whole pregnancy, to basically abolish the risk of them suffering from an overdose. So they are very, very effective. So challenges on the one hand, why don't we give it accessible to more people that need it? But the other one is the one that you see here. Despite the effectiveness of these drugs, we're observing, at least in the United States, that in average, 50% of individuals that are initiated on medications for opioid use disorder, in average, actually will stop taking their medication in 6 months. And this is a meta-analysis that was just recently published that actually reports it for different types of medications. For methadone, 64% of people are retained on methadone, and methadone is, in the United States, the medication that leads to the longest retention, the highest rates for retention, and this was based on studies that were either 2 weeks or 3 years. The retention for buprenorphine is slightly lower, it's 54% for studies that were evaluating 2 weeks to 1 year. For naltrexone, it's slightly less, it's 41% for studies done between 2 months and 9 months, and it's only 30% for controls. So overall, thanks very much. Overall, what we are observing is that methadone is superior to buprenorphine in retention of treatment. Buprenorphine is superior to naltrexone in retention of treatment, and all medications are superior to control. But a question in research, and I think that we should be looking into, is how to optimally keep people that are initiated on medication on treatment. And that is, again, an extremely important area of research, and with great opportunities, I would say. So what we are doing right now to address the question about how do we expand access to treatment is we've built up large networks of research that are creating partnership with the providers, whether the providers are on the healthcare system, and the providers in the healthcare system can be specialized clinicians like emergency departments or primary care physicians. They can be involved with the healthcare system like pharmacists or nurses. But we're also creating a network with the justice setting, because at least 20% of individuals that end up in the jail system have an opioid use disorder. And as of before the COVID pandemic, very few of the jails and prisons provided access to treatment. And yet people that ended up in jail or prison had a great risk, much higher risk of overdosing when they were released. So the mortality is much greater. And then we established a new study, the Healing Community Study, that basically is focused on 4 states. It's a very ambitious prevention treatment intervention that brings together healthcare, justice, community, the state and private industry to bring up models that can then be used to translate into other states with high rate of mortality. So all of these are large investments that have already started to provide very specific answers that are valuable to expand, to address some of the gaps that we have in implementation science. For example, through the clinical trial network, we were basically able to show through a study done led by Yale University that implementing buprenorphine treatment in the emergency department by the emergency physician significantly improved the outcome. So this was a study now published many years ago. It has been replicated, showing that much better actually outcomes when the buprenorphine is given. This is at baseline. 30 days later, you can see much better outcomes than those that you see with referral or with brief intervention. So just giving buprenorphine in the emergency department is actually an intervention that is relatively easy to do and that can significantly improve their outcomes. Taking basis of that study, what the researchers are now doing is, if we're going to be giving buprenorphine in the emergency department, what is the best way to do it? So this initial study was done with very low dose buprenorphine with the idea that then the patient would rapidly be linked with treatment. A recent study published last year, for example, showed that the emergency department physicians or the advanced practitioners could initiate buprenorphine in the emergency department with a high dose. They could start with 12 months of buprenorphine or more. The patients did not go into withdrawal, and that made it much easier to manage. And they could do it quite rapidly, within 4 hours. So this made it much more practical to apply the use of buprenorphine in emergency departments. And this is the type of models that are necessary to actually then incentivize clinicians to start treating people that end up in the emergency department with an overdose or not, but with an opioid use disorder. In the justice setting also, the effect sizes that we are observing in terms of when you implement interventions for treatment of opioid use disorder are very large. And so we need to document that, because that is what ultimately, hopefully, will drive policy to change a culture that has been very, very negative towards treating individuals with substance use disorder in general. This is a study, the first, probably, was done very notable in my brain, because it shows an effect at the whole state level. It was an intervention that initiated treatment for opioid use disorder with medication in all of the individuals that had it in a jail or a prison. And what they observed in this particular study was when they looked at the individuals that were released, with respect to the year before, they saw a 60% reduction in overdose mortality when they implemented treatment, 60% over a year period. And that actually translated at the whole state in a reduction for the whole state of a 12.5% decrease in mortality. So you have an intervention that has a population effect size, and that highlights how important and impactful that they may be. And then I chose a very, very recent paper that to me actually speaks for itself. It just does not use statistics, because you don't need statistics. And it was basically comparing in the justice setting interventions with buprenorphine, which we see here had a big effect at the population level. This was basically immediate release buprenorphine, sublingual buprenorphine. So here you have the sublingual buprenorphine in red versus a new formulation, extended release buprenorphine. You get buprenorphine on a monthly basis. And we had a session 2 days ago. It was very interesting to hear about it and the pros and cons. Well, I'm going to show you the pros when you implement it in the justice setting. We see already benefits from sublingual. So let's compare relative benefits of sublingual versus extended release buprenorphine. And the blues are the extended release buprenorphine. And it is initiated also, think about it, 1 month before the person is going to be released into the community. So it's not even applying the intervention while they are incarcerated. And you can see that basically a significantly higher number of them retained in any form of treatment. They are much, basically, again, at week 8, much higher numbers that are retained on treatment. A much higher number that have negative urine samples, and much lower numbers of reincarceration. And again, these are reds. These are individuals that already benefit from sublingual buprenorphine. Bringing forward the concept that, as we're discussing, what are the unique opportunities that we have for this extended release formulation of buprenorphine? We should consider the easiness of their application, for example, in justice settings, but also the easiness for those individuals when they are returning to the community to stay in treatment. Because you have been incarcerated and all of a sudden you have to go to a treatment program, you have to navigate multiple situations, and being able to be protected for 1 more period actually gives that ability to stabilize you and the opportunity to gain the networks that can help you achieve sobriety. Again, this is another example about how implementation science can show you relative benefits of one intervention versus the other in the terms of the context. And this is a study that was published. This is Canadian-based, and I want to highlight it because this is another area that we have all been struggling on as it relates to the use of methadone treatment. Methadone is a wonderful drug. It actually, as I showed, protects against overdoses. It leads to higher retention in treatment. But there is a lot of stigma for methadone, and many patients don't want to go into methadone clinics, and many patients complain that it is very difficult to try to remake their lives, keep a job, having to go on a daily basis to methadone clinics that in many instances are not nearby. And so this study just compares the differences in outcomes on individuals that had to go to the clinic on a daily basis. These are, whether it's blue or red, doesn't really matter, versus the lighter one. And in terms of opioid overdoses, these are individuals that are getting 5 doses. It's not that they even are getting 1 month of doses. Lower rates of overdoses, lower rates of discontinuation of therapy, lower rates of interruption of therapy. So to the extent that we can learn from the COVID pandemic, that forces us to implement these low threshold methadone with take-home doses that have not resulted in negative outcomes, but in other cases indicating that they may have benefits. I think it pushes us to think about, are the policies and practices that we're using the optimal? And my answer is they don't seem to be. In the meantime, research is advancing, and advances in COVID, for example, in terms of vaccines, in terms of immunotherapy, are things that we can take benefit to actually implement it for development. We've been working with researchers for development of vaccines, for developments of monoclonal antibodies, and the advances that came with COVID, of course, are going to affect those developments. In particular, I think that to me, where certainly I may be wrong, but the way that I interpret the data, what has happened to all of us vaccinated, boosted, and everything else, how important titers of antibodies have been. It's something that we've recognized in the past about why vaccines have not been effective, had not reached the effectiveness necessary for the FDA to approve them, or cocaine and nicotine, because we didn't build sufficient titers of antibodies. And the question here is, when you're taking a drug, think about it, the circulation of the drug. What you're trying to do with a monoclonal antibody or with the antibodies from the vaccine is to trap that drug in the plasma so that it cannot get into the brain or the other organ, just trap them. You need high titers for that because the doses are much higher than what you have in terms of viral loads in the blood. And so based on that, my perspective, and again, I may be wrong, I mean, that's why we do science, to see if we're right or wrong, is that in this respect, monoclonal antibodies are likely to be more effective than vaccines. And with again, the technologies from HIV and from COVID, we have now monoclonal antibodies that are longer lasting, that have longer half-lives because they are not degraded as rapidly. And we're currently evaluating monoclonal antibodies in humans for methamphetamine, and we're also on phase 1 clinical trials for monoclonal antibodies for opioids. So this is an area of a lot of research. Hopefully we will see that the sort of ultimately the extent to which we can predict whether it's going to be beneficial or not is not always determined by the positive results that we're getting in the animals. I do want to highlight transcranial magnetic stimulation, direct electrical current stimulation, ultrasound stimulation, peripheral nerve stimulation, direct brain stimulation, because all of these neuromodulation technologies are going to be advancing, and we're going to be learning how to implement them. And I think that we need to expand their opportunity for studies and for applications in substance use disorder. Obviously, we're using them for the treatment of depression. It has been approved for the treatment of nicotine addiction. Peripheral nerve stimulation has been approved at the FDA for the treatment of acute opioid withdrawal. And we need to actually, again, be clever and question, and that's why I was sort of saying, what is it that we can do to improve retention in treatment? And it's perhaps using of medications with neuromodulation technologies may in terms help us improve retention in treatment. And importantly, if we know what are the neurocircuits affected in an individual, because certainly there is heterogeneity in individuals suffering from substance use disorders, such as there is heterogeneity in patients with depression. To the extent that you can actually generate a pattern of what is the unique signature for that individual, you can apply neuromodulation to actually overcome those specific deficits. And I want to end my presentation with this curve, and importantly, because it actually highlights something that brings me back to the notion of prevention. We started, yes, the prescription opioids were initiating the crisis, and it was a disaster in the United States. A terrible disaster for which the healthcare system has part responsibility, and we need to learn from our mistakes so we don't do them again. But as the number of prescriptions went down, we saw that the contribution went down, and that started to happen around 2011. But in 2011, we saw an increase in heroin. But in 2016, 2015, we started to see an increase in fentanyl. And we were not paying attention to the psychostimulants. And if you look at the rate of increases in stimulant deaths, you can start to see that the curves are very similar in terms of their steepness. So we are not going to solve the overdose problems by just focusing in one drug. Nor are we going to solve it by trying to put band-aids on this or that condition. We're going to solve it by addressing that important question about what is it putting people at risk for taking drugs. And that's where prevention comes along. And this data came up past 3 months, actually, because I think it is, and it captured my attention because it was a very chilling for me to observe this. For the first time ever in the United States, we're seeing teenagers that are in high school dying from overdoses from fentanyl. And the issue on this, so this was overdose deaths in adolescents are very, very low. These are kids 15 to 19 years of age. This is all drugs. And they basically, for all types of drugs, they have been going down. And teenagers, for example, in 2021, have the lowest rates that we've ever seen of heroin use ever since we have been recording in the United States. Lower rates of cocaine use since we've been monitoring them. The same thing with methamphetamine. The rates of drug use, and this has been dramatically reduced during the COVID pandemic, have been going down. But the mortality from fentanyl has gone up. And the question is, what is driving that mortality? And look at this mortality actually steeply rises and then continues this way. If they are not taking heroin, if they are not taking methamphetamine, how are they getting that fentanyl? What teenagers are taking are prescription medications. They take Adderall to study for exams, they take benzodiazepines with mixed alcohol, or because they want to sleep, or they take Vicodin because it's sort of actually, again, to party. And this is what we currently are observing in the US illicit market. This is the number of illicit pills, illicitly manufactured pills that contain fentanyl. In 3 years, the rise in 3 years, from 2018 to 2021, we went from 290,000 pills detected Cs, which is a reflection of the amount that's coming into the country, to 9.7 million. That's a 40-fold increase in access to illicit pills that contain fentanyl, 30% of which is sufficient to kill someone. So to the extent that teenagers are actually consuming illicit prescriptions that they are getting from the black market, they are putting themselves at risk of overdoses. To the extent that a person may be seeking these drugs in the illicit market because they cannot get them prescribed by their doctor, they have pain, they cannot sleep, or they want a stimulant to perform better, they are putting themselves at risk for overdosing. So the population at risk has just expanded by the nature of the types of drugs that we have, which again highlights the notion of how do we prevent drug use and how do we prevent harmful drug use. But right now, certainly in the United States, harmful drug use is changing because the risks are so much higher with the dangerousness of the drugs that are marketed. And I want to end up with this slide. I like to end up with these slides because I think it tells us a very, very strong story that actually defies many of the concepts and the stigma that people have when it relates to people that are taking drugs. People that are taking drugs and become addicted have done it this on themselves. They want to have high, they're doing it for pleasure, they are morally responsible, blah, blah. This is the reality of people that are taking drugs. And if you go, and I actually walk all over the place, this is a person that is injecting opioids. But if you walk around in places that are people that are drinking very, very heavily or are smokers, and you see that these are people that are among the most disenfranchised and very, very isolated, living in really awful conditions. And with the homeless population, the use of methamphetamine has gone up. And this is among very, very basically one of the ways that these individuals that are living under these conditions can escape a reality that is extraordinarily aversive. So to the extent that as a society we create systems like this one, we're going to have people that are going to be very vulnerable. And those that have been vulnerable from childhood are going to actually be accumulating that vulnerability unless we do interventions to actually remove that disparities. And this is a very simple study done in rats that tells us a lesson that we could learn from these very simple experiments. A rat is given 2 levers. On one of them, they can press for a drug. It can be heroin or methamphetamine. You get the same results. And in the other one, they can press a lever for a social contact that is positive. So you're giving a choice. You can choose drugs or you can choose to press the lever for a social interaction. If you're giving a choice, these animals prefer the social. They do not take heroin. If you're given a choice, they don't take heroin, but you need to give a choice. And also, if that choice of the social interaction is penalized, such that when the animal presses the lever for social, they deliver an electrical shock, which to me is sort of like a discrimination against someone. It's a very, very aversive response to a social interaction. Then they stop pressing for it, and their drug intake goes up. So what are the lessons? The lessons to me is that among the most powerful factors that we have for prevention is the building of meaningful social interactions that are positive. And at the same time, the most negative factors that we have to increase the risk of someone for problematic drug use and addiction are aversive environmental interactions, discrimination, criminalization, stigmatization. This is a simple experiment, actually, that speaks for itself. And it is also telling us that if we are going to do prevention interventions, we need to provide with alternative reinforcers. And with that, I want to thank you for your attention. Thanks very much.